income countries is typically about 90%, while in low-income countries it's about 30%. And then even more, I would call it less serious conditions, but anybody who has suffered from migraines, as I do, and I was actually talking to someone whose son has chronic headaches that he has almost constantly the other day. Women are 3 times more likely to suffer from migraines, more than 3 times more likely to suffer from migraines than are men. It often has a menstrual component to it. But as someone who suffers migraines, I know how devastating that can be. Um, and, with respect to this, the rules around healthcare and the establishment of patient relationships can often impact the amount of providers and the amount of care that people get. As Krista and I were talking about as prepared for the call, the rules that impact the establishment of the provider-patient relationship and prescribing of controlled substances can be dramatically different state to state. Controlled substances typically are treated more restrictively than ordinary prescriptions. States have varying different regulations. And so, for example, if you took California versus Virginia, in California, you can go ahead and have a patient um, create a telehealth visit, go ahead and establish a patient-provider relationship through telehealth. They can fill out a questionnaire. In California, you can have multiple modalities like asynchronous, in certain circumstances, and audio only. And patients can fill out the questionnaire, do a video visit, and get a prescription, which makes the availability of healthcare and the ability to get your conditions treated much more readily. Whereas in Virginia, the provider must do a physical visit, and you can't use a questionnaire to establish a medical relationship. There are tougher requirements around real-time communication, and audio only cannot be used for an initial exam. There are similar requirements around network adequacy. And so, for example, if were to look at those similar requirements, what you would have is you could have, at least theoretically, the same number of providers in California and Virginia, but you would have much more access in California than you would in Virginia. And even though Virginia is a fairly liberal state. Politically, it's typically viewed as a purple state. So patients can be reached more remotely, and flexible audio and other telehealth policies, can be a workforce multiplier. Moving more towards, the LGBTQ plus and queer community, this can disproportionately affect LGBTQ patients because they tend to need more culturally sensitive care. They also tend to want to find more providers who are more similar to them, and that often is very, very difficult, in many localities. It tends to be, I would say, fairly easy to find a, white gay male provider. But if you're looking for a black transgender female provider, it's going to be much harder. So if you live in areas where there are not, gender-affirming clinicians, if you're seeking specialty behavioral services, if you're seeking mental health providers who are going to be able to, relate to your condition, make you feel comfortable. I don't say condition, excuse me, that's a bad word to use. Your gender identity. If you require hormone management, if you need sexual health services, it's dramatically different if you can find the right provider. The other thing I would say is, you can also um, uh, depend on telehealth, and in certain areas to um, reduce the stigma, for some of what you're doing. Because if you live in a fairly conservative area, you would not have a similar issue or stigma that you may have in other areas. For example, some of these can disproportionately fall on people in the LGBTQ plus community. So a mandatory, video visit can create barriers for rural patients. Restrictive prescribing rules can, create delays in prescribing, hormone therapy or PrEP. You could have, limits on asynchronous care can increase the appointment burden. State-specific licensure rules, particularly in this day and age, could reduce the ability to get specialized care providers, and the lack of AI guidance can create, uncertainty around automated tools and triage support tools. Last but not least, what I would say is, around data ownership and management. Contract provisions can vary dramatically state by state. Often the practical question isn't who owns the data, in the quite literal sense, whether it be the patient, the provider, the facility, but who may access it, use it, and disclose it, and what kind of consents were applied, what kind of promises, guarantees, so to speak, were made to patients, to vendors, to regulators. So it's really interesting. You've got to look at who has the right to use the data, to train the models on the data, concerns about what happens if the contract terminates. Will that go with the vendor? If it's virtual care, how is it handled through BAAs? And then, also making sure you understand, what happens if there's, classic data leakage problems, and what permitted uses are. So one thing I would argue is that, some of the biggest regulatory and investment challenges are frankly around the fragmented, state by state regulatory environment. You can often, in this environment, have a very clinically sound um, tool, but scaling it nationally can be very difficult, and that can make it difficult to obtain funding. That can make it very difficult to grow the business, which is the other side of that funding coin. If it is difficult to grow the business and scale it quickly, and get contracts, that will make it difficult to get the funding. It may require redesigning of workflows. It may require redesigning of the patient onboarding process, and often does, different prescribing patterns, different privacy policies, and as we're all seeing now with AI, very specific AI governance mechanisms and AI contracting language. So with that, hopefully that's a little bit of a decent overview. I know it's been a bit. I will stop there and see if there are any questions I can answer.
Thank you so much, Jeff, for such a thoughtful conversation and presentation. I'd love for you to readdress a little bit about the population, specifically dealing with women and those that are part of the LGBTQ community. How is that quantified on Wall Street? And did you mention that it's $400 billion in lost revenue?
No, it's currently $430 billion in revenue, projected to be $600 billion. But I think quantified on revenue by looking, obviously you look at the demographics, you look at obviously with, just women, the number of women patients, women are traditionally the ones who not only manage their own spending, but tend to manage the, healthcare spending for the entire household. But then it's broken down depending on, you have, prime age groups, but typically between 18 and 45, over that, and then, pre-18. But then it's also can be broken down by condition. Obviously, breast cancer, cervical cancer. You have, the issues that are, maternal health and, then menopause. Queer health, you have going on with, gender-affirming care, and hormone replacement therapy, other things, but also a very big issue around mental health support,
Mhm.
finding the right providers that, are culturally sensitive and culturally appropriate.
Mhm. So the estimate of 430 to 600 billion, that's revenue that has already been generated by that population.
The 430 is estimated of what the current revenue is now by McKinsey, and that's estimated to grow to 600 billion by
Mhm.
2030.
That is potential revenue lost if that patient population is ignored. So
Absolutely.
there is incentive by Wall Street and those in Silicon Valley to create products to help this patient population and to meet their need.
Yes, and as I pointed out in my opening remarks, if you look at closing the gap in, cervical cancer, the estimates are that there's $28 billion there alone in, in lost revenue, lost productivity in terms of GDP by 2040. Even just little areas, as I said, like migraines,
Mhm.
lost productivity at work, and other things, obviously have a large impact on, the economy, and then, certainly the ability of, different providers and people to treat those populations.
I have a question, Jeff, for you, but I'd also like Claire and Sean to jump in on this. There are so many companies out there that are proposing to be fluent in this space. And, there are some bad actors out there in the digital health space. We saw that during COVID, that companies claimed that they were able to diagnose COVID just by a telephone call. And of course, when you lack insurance or lack the ability to access healthcare services, your next your next opportunity is to potentially utilize one of these online resources that has a lower level of quality care, and some might even argue doesn't even meet the medical standard of care. So, how do we make sure that these are sensitive patient populations? And how do we make sure that they get access to good quality care in a digital environment? And so I'd love to hear from you, Jeff, and then Sean, because Sean runs URAC, which is an accrediting organization, and Claire has worked very closely with Bethany Corbin on the book FemTech Revolution, and they are keeping their own database of companies that have essentially an algorithm of what makes a good digital health company in the femtech and queer space. So I'd like to hand it over to you three to answer that.
Okay, do you want to have them go first, or you want to me to go first, or?
Well, yeah, Jeff, why don't you go first, and then we could hand it over to Claire and Sean.
I think a couple things you can look at, and one thing that I always like to look at when I was an analyst is you can look at, what has the company said in the past? What has management held itself out to be? What have they suggested that they were going to do, and how have they held to those promises?
Mhm.
So, it could be as simple as, what did management start this company out to be? Have they then pivoted to something else? So have they fulfilled, that promise? Who are some of the people involved in the company, and what have their, past uh, successes or even lack of success been? Has that lack of success been because of product market fit? Has it been because of inability to effectively treat those patients? And then going kind of along those lines, who are the backers to that company? Who are the venture capital investors? Who are the either family offices or private individuals who are backing that company? Have they backed similar or other types of companies, and have they held to what they said they would do? I think it's often, as simple as that. And then, last but not least, is there's always, state and local regulators who you can look to see if there have been complaints about what these people are doing, how they're doing it. And, you certainly want to be vigilant for that.
You bring up a good point. Some of this stems from an uneducated investment team that knows investment, but they don't necessarily know healthcare. Claire, what are
Right.
your
Let me just add one other point. I'm sorry, and I don't mean to interrupt, but one other point is you often see people who, as we've talked about before, are very technologically savvy, but not very healthcare savvy. So what I would always look for a very, strong healthcare team and not just one or two, chief medical officers or chief clinical officer, but a strong, savvy, either investment, board or advisory board on the medical side.
Yeah, I mean, you're 100% right.
Yes, yeah, exactly. So, a few things, Jeff. So, I know you mentioned policy. That's a big one. So, it's going to be policy on the state side and federal. And then, exactly what you mentioned, Jeff. So, Bethany Corbin and I are working to build this website that will be like a searchable database of all of these FemTech products and services. And we evaluate them on four different dimensions. And one of them is exactly what you said. So, I'll start from the top and go down because it helps with the make the acronym make sense, but it's called safe scoring. So the S is for security and privacy. That's where we look at all these different companies to see how well they protect the personal health data of its users. Do they use encryption? Do they have encryption standards that are equivalent to what their industry is? What are their sharing practices? We read through all of their privacy policies. And then the second one is accuracy. So we look and see, is it scientifically backed? Have there been any clinical validation or peer-reviewed research citations? And all of that should be so easy to find on their website. And then the third one is exactly what you were saying, Jeff. It's foundation. So it's what's the company's track record, expertise, the team's credentials, the funding transparency, regulatory compliance, all these different things. And then the last one is equity. So does this product or service work for all different body types, all identities? Do they have a stance on DEI? Is it inclusive in design? With their research populations, does it involve a lot of different people, accessibility features, all these different things, and price as well. So we want it to be economically accessible as well. So we evaluate all of these companies on those four dimensions. But and that's where we are doing it because that's so much work for individuals to do on their own. Like I have a PhD in women's health and I still get all of these FemTech ads on my Instagram, all these other things. And my immediate thought is like, oh my gosh, that would be so cool if that works, does it? And it takes me so much time to go in and figure out if it's actually a solution or not. And one thing I'll say too is with some of these companies, it's really easy to find this information and provide a score. But for others, it's really, really difficult. Like one I'll mention, I don't know if you have all heard about a company called Ava. They make the fertility bracelets. They're really popular. They were like one of the very first companies to start using machine learning for ovulation prediction. And they're really accurate, but the company was created by a Swiss team, like almost maybe a decade ago, maybe a little bit less. And then in 2022, it was acquired by a company called FemTech Health, but FemTech without, I think it's just FEMTEC. But that company went under and then it was bought by Awesome Health and then another company. And those few companies that keep shifting, they just go around and buy different FemTech products and then they go into zombie mode where I can still go on to Ava Fertility and buy a bracelet right now and use it. But I can't contact customer support. I can't get any of my data. So we have no idea how any of the previous data existing, what's happened to that. So there's just a lot of issues like that and it took me a long time to track down all of the information. But if you just go to the website, it looks legit. You can just order it and I can receive a bracelet and start using it. But Yeah, so that's where it can, even though I have all this expertise in all these different areas and working with the team, it still takes us a long time to find all this information.
And so is it membership based, Claire?
For the company we're
Companies?
creating.
Yeah. Oh no,
Um,
the FemTech companies that keep getting bought up and resold.
I don't think it's membership based. I think it's hard to track down the individuals who are a part of them, because they keep shifting and changing names. But I found like a few people to associate with them, but I don't think it's membership based.
For companies that are membership based that are in zombie mode, it's going to be hard to cancel. And so that
Mm,
sparks FTC violation with the click to cancel rule. So there's just policy issues piling up.
yes.
What are your thoughts? I mean, running URAC, you were the first ever accrediting organization to do a telehealth accreditation, which we were so supportive of, and then the AI accreditation, which we were very supportive of and worked with you a little bit on. Talk to us a little bit about how an organization like URAC is able to identify good and bad digital health companies in this vertical.
Thank you, Krista. Really appreciate the chance to be on this call. You know, quality care is quality care, and so we've been doing telehealth accreditation now for coming up on a decade. And so when we talk about an accreditation, we don't just check policies. We actually make sure that they're following their policies. So we take this all the way through to where we have auditors who basically go in and work with the organization from scratch, starting with everything from risk management, credentialing, quality improvement, quality monitoring, business associates agreement, data protections, privacy, all those sort of things. We even go down to employee diversity, equity, and inclusion standards, clinical leadership, technical leadership, all that sort of stuff. And that's even before we move into the clinical care, where we move into clinical practice guidelines. We move into escalation protocols for if you get on for a call and you just say you've got a runny nose and you get on there and it's like, well, my nose has been bleeding for 4 hours. You know, how do you escalate those things? And I think it's incredibly important, especially when we talk about access. You know, access as somebody who trained in rural family medicine, the promise of telemedicine, you know, continues to grow, but also as access increases, bad actors increase. And so you really have to look at who you're dealing with. We put our accreditation out there 10 years ago. We had a little wave of activity during the pandemic, but quite honestly, a lot of it's fallen off. Unless the people who are paying for the service or investing in the service feel that an accreditation is an appropriate safety and quality check, it's just not going to go anywhere. And that's really sort of what it comes down to for us. I mean, we're on our fourth version of telehealth standards. We've been doing this for a long, long time, and we've had organizations come to us who didn't know what they were doing and who couldn't get accredited, and we're glad they couldn't get accredited. Accreditation is not something you can buy, it's something you apply for. And we take our high integrity and low conflicts of interest really seriously. We're independent, we're nonprofit. When you look at our board, it's the American Medical Association, it's employers, it's the American Hospital Association, it's nurses, all these different groups. We're excited to work with CTeL on programs when it's appropriate, but really sort of, you know, to old people like me, it's the good housekeeping seal of approval is somebody actually went in and checked to make sure this is right. And there's a whole lot of organizations making promises out there, but when you check on them, there's not even people behind the promises, let alone following the promises. So as I'm very frequently saying on AI these days, you know, in the wild, wild west, somebody needs to be a sheriff. And in telehealth, we've been the guardrails for almost a decade now. And we would love for everybody who has a good quality organization to come to us and seek our accreditation. It's not that expensive. We don't do this to make money. We just think that you need to have somebody who knows what they're looking at, who's been doing this for 3.5 decades, look behind the scenes and make sure that this is not a fly-by-night organization and that the quality standards are there before you give them the trust, before you give them information that creates vulnerabilities. And that's what we really think is important. So we're going to be up in New York. We're going to talk about this. I talk about it all the time. You know, we're best in business for accreditation according to Modern Healthcare Magazine. We're the only accreditor who's earned that designation the past 2 years, and it's because we do really good work. And if somebody starts out good but they turn bad, you can report them to us, and they can lose their accreditation. So this is not something where we just do a snapshot in time. It's a 3-year accreditation, but we can check every single time we get a grievance or a complaint on an organization that we accredit. We go in and we check. And I care very deeply as a physician about the care that people receive, no matter where they are or who they are or what they do. I believe everybody deserves quality care. And so UREC is out here trying to say what quality is, and happy to talk to anybody anytime about what we're thinking in this space. But we've been thinking about it for almost a decade now. So really appreciate the chance to talk about what we've been doing. And if anybody has questions, reach out to me and talk to me, or you can ask me now. I don't care. But thank you for the chance to talk about our program.
Hey, Krista, one other quick point I wanted to make is just in terms of, what people are doing around AI, as it was mentioned, I teach responsible AI. And when you get to some of these patient populations, particularly, in LGBTQ plus and queer, the patient populations are often not large. And it's very difficult to train models on some of these patient populations. So when you get some of these companies, and everybody is, saying we do this with AI, we do that with AI, ask them what they're doing, how are they training their models, if you get a model that's been trained on a cisgender population and then kind of, applied to a queer or femtech population, it's not going to work. It's not designed appropriately. The other thing is, just because someone doesn't use an AI-based model doesn't necessarily mean it's bad, because if you have a small population, you can use a simple regression model that may help you, sort a smaller population and lead you to some indicative things. And that may be helpful as well. So I think you have to, when you get to some of these smaller populations, you have to be careful about the terminology.
I'm so glad you mentioned that, Jeff. That is um, such a big piece to algorithm building, is being able to have the right employees that are building these products and sourcing from the right patient populations. So yeah, it's interesting that you bring that up, because in the conversations that, and Claire, the conversations that we have had with tech companies, and Sean as well, they have a very they might not necessarily have those types of diverse patient populations that are also part of their employee that are staffing these operations internally within their companies. So I always kind of scratch my head and go, how are you able to make sure that this is a product that will meet these patient needs? And are you doing research? Are you looking at academic research? Like, if you don't have those employees, that's fine, but how are you compensating for that? Are you looking at academic research to build these models?
Yeah, and not only academic research, but oftentimes it's very helpful just to bring in, kind of, I don't want to call them advisory boards, because it doesn't have to be an MD or a PhD. It can just be someone, a group of people from the patient population saying, hey, these are things we run into. These are things we are worried about. When we go in to talk to a doctor, that we are concerned about. That are particularly sensitive to us, that may not be in your model, that may cause something to not come up. Because if it's not discussed in the patient visit, it's probably not going to come up in a lot of models.
Chris, to the other thing I just mentioned, I'm not even trying to talk about our AI accreditation. I mean, we have an AI accreditation for developers of AI tools and users of AI tools, but
Different.
whether it be in telemedicine or AI, the bigger the claims, the bigger the responsibility to prove them. I think we have to really be careful about giving our trust to anyone or anything until they've earned it. And sometimes desperation, whether it be somebody who's rural who just is looking for some feedback, and those are, I mean, I think AI tools are fantastic for translating medical jargon speak into common language, but really having a trusted care relationship, that's a higher bar that someone has to prove it to me before I'm going to believe it. And the bad news is that with AI tools, all this stuff can look really good on your screen. And that's why we go all the way into credentialing and teaching and monitoring and training. And also, one of the things we don't talk about in AI is that AI makes mistakes. And we don't say it can't make mistakes, because I practiced with other doctors who made mistakes too. So I mean, it's not like I'm going to throw a higher bar out there for AI. But what do you do when you find that mistake? Do you have a feedback mechanism to address it and correct it? And that's, I say most accreditations are about 80% what you'd think of if you were just sitting there thinking about what's good stuff. It's that other 20% where we've discovered it because we've turned over a lot of rocks over the years and found really hinky stuff that was going on. And so we update our standards. And with AI moving so fast, having standards that move is incredibly important because regulation is not going to fill in this gap. And in AI and in telehealth right now, unfortunately, litigation is what fills in for the gaps in regulation.
Yeah.
Brings up a good point, because on the June 25th meeting, we'll have 3 separate medical malpractice firms that will be there. Sean will be on that panel presenting, and we'll talk about how AI is there's one medical malpractice company that is ensuring AI risk for healthcare, and that is specifically for the Sandbox case in Utah, or Sandbox, not case, but the Sandbox, it may be a case soon, but the Sandbox pilot. And we have to also have an awareness of the fact that we are asking clinicians to participate in using AI in a way that might not be medically appropriate, and that puts their individual license at risk. And so the thing that I love so much about what Claire and Sean are doing, you're almost operating almost in the identical space, but a little differently. And I hope that you guys will continue this conversation offline, but we have to be able to identify the appropriate companies and then direct patients there. But most importantly, we have to be able to identify the appropriate companies so that we direct physicians and clinical providers to those companies. There are so many bad companies that do not care about putting physician and nurse licensure at risk. And we're in the middle of a clinical workforce shortage. We do not have the opportunity right now to lose any more providers because they were steered towards an inappropriate company because a locum staffing company said, yeah, they're okay to work with, when in fact they're not, and they just didn't have enough information to be able to make that call.
One thing I would suggest also, Krista, is sometimes it's not malicious. It's simply lack of knowledge. As I said, as we
Sure.
talked, there are people who are technologists who are
Sure.
approaching this strictly, from a technological perspective, and they simply do not know, and you'd be surprised, you'd be shocked. And so, when you do have people that are referred certain places, it can't hurt for them to ask, say, hey, what are you doing about this? What are you doing about that? Because some people literally do not know, to the point we actually had someone say to us that they were 80% HIPAA compliant, and we were like, that's not a thing. It's 2 problems with that. One is it's binary, and 2, by saying you're 80% HIPAA compliant, you've just subjected yourself to more fines because you've acknowledged that you're not HIPAA compliant. That was a little bit of a problem.
Offline, I'm gonna see if you'll tell me the company, because but yeah, I mean, you're right. I don't think it's malicious, but at the end of the day, I've been doing this for 18 years, and I know that when I talk to investors in Silicon, we call that the 20% guaranteed win in court. Thank you, Micah. I do know that many of these companies have been told by legal counsel that they need to pull back, and they are saying, no, we're not going to. And so I believe there's a small percentage of those that are not leading with malicious intent, but I do believe that the majority of them that are that are engaging with patient populations are moving to meet investor demand. And they have an awareness that their model has some compliancy issues, but they're willing to push that legal and regulatory envelope, especially in the AI space, where we're looking at companies with $7 billion evaluations. They're saying we have more money than God, we will take on the lawsuits.
Yeah.
Yeah, I often say that the AI space looks like the telemedicine space did during the pandemic, but add 2 more zeros. I mean, the money amounts are just ridiculous right now, and the valuations, and they're doubling down on healthcare because that's where so much money is. And even all the free tools that are out there for doctors to use aren't going to be free for long because they need to cash some checks. And unfortunately, in the meantime, patients are, there's so many more actors in the space that of course there's going to be more bad actors, but there's also going to be more good actors. And we did this program. I mean, the Joint Commission just launched their AI accreditation for hospitals last week. And we say it's a lot bigger than just the hospitals, folks. And so that's why our AI accreditation is for anybody in the medical space. So always happy to. People should look at our standards for telehealth. The standards at a glance are out on our website. They should look at our standards for AI. Those are out there on our website also. But this is a dangerous time right now, and in dangerous times, bad people come in and try and offer things they shouldn't be offering.
We have about 1 minute before we end this conversation, but I do want to, before I hand it to the panel, I wanted to mention that we are hosting an event with Nixon Peabody on June 25th. We are so lucky to have Jeff and Sean that are going to be with us as speakers, and Micah and a few other medical boards. And we're lucky enough to get an attorney general that's going to be there talking about all things AI. That meeting will not be recorded, but if you are interested, we might be able to make room for you. I'm sure we always have space for those that are interested in this topic. So if you need registration for that, I'm happy to bump it to you. Just please reach out to me via email, kristanatoli@ctel.org. Moving on to the next topic is this is a coalition. So we would love to host these quarterly coalition meetings. CTeL is the first digital health organization that has launched a specific coalition towards FemTech and queer tech healthcare. And we are hoping to increase the visibility of this coalition. And so this coalition is free to join if you're part of CTeL or not. So please feel free to share. The more the people, the merrier. And then I want to leave it to our panelists to see if they have any closing, or I would love to leave it to Jeff and anyone else on this call to see if you have closing remarks.
No, I just want to say I think there's a lot of things that could drop on the regulatory front. There's the the HIPAA privacy and security rule updates, which were supposed to drop in May. I don't think they haven't dropped yet, and we'll see what's going to drop potentially. And I would just keep an eye. There's a lot going on in the regulatory space. And I do think I am looking forward to the panel on the 25th. I think it'll be incredibly interesting.
Yes. Thank you. We will host our next coalition meeting in September. We wish all of you a really happy and healthy summer and get all rested up because there's going to be a lot of activities in September that CTeL will be hosting and in the fall. So we look forward to you joining us. Take care, everyone, and hopefully see you on June 25th. Bye-bye.
Thank you so
Bye-bye. Thank you.
much. Bye.